Good afternoon, ladies and gentlemen. Welcome back to our afternoon session of the World Cancer Leaders Summit. I hope you enjoyed your lunch and you're ready to share in more very, very important sessions. We will have some keynote speeches, and we also have interview sessions with Charles a little bit later, and a chance for you to have a say as well. But right now, it is my great pleasure to introduce Dr. Saunthari Somasundaram, who is the president of your host, the National Cancer Society Malaysia. She's also a UICC board member. She's a pediatrician by training, and she brings over 20 years of experience in cancer control in Malaysia, combined with personal experiences in cancer support. She also sits on various committees on tobacco and cancer control, and she's been involved in programs with the WHO, IAEA, and UICC, of course. Ladies and gentlemen, please welcome Dr. Saunthari Somasundaram.
Thank you, Yasmin. As always, you make me sound so fabulous. Good afternoon, everybody. I hope you had a wonderful lunch, and I hope I'll be able to keep you awake for the next 15 minutes. I'd like to bring the discussion down to a little bit more of a personal level and on a patient level. So I was asked to talk about understanding and addressing inequalities in cancer treatment and care. So I just thought I'd start with this slide, something a little bit different. So what do these things have in common? So if you just look at the top slides, the first is when Alexander Fleming actually left a petri dish out for 2 weeks and it got contaminated. And that was the creation of penicillin. The middle one is when a scientist dropped a flask full of plastic cellulose and nitrate, and it didn't shatter. And that's how we came to get safety glass. And these things are success stories, little things, but huge successes in the world. But little things can also have issues. The third one you see there was when a hunter got lost and lit a fire to signal rescuers. And that caused the largest wildfire in California's history. So, little things. The next three, the feet, the family, the house, just keep that in your mind when I go on. I like to, since it's the 1st of October, I'd like to talk a little bit about breast cancer as we celebrate Breast Cancer Month. And I also like to talk about the region. And this is a study which was done by IEU, Breast Cancer Report in Asia, which came out a few years ago. And if you look at the countries of Thailand, Malaysia, Singapore, we're neighbors in this region. But if you look at the mortality versus incidence rates, there's a huge difference between them, especially from Singapore to Thailand and Malaysia. And even though Malaysia has got a higher GDP and is a high income country compared to Thailand, our rates are actually much worse than Thailand is. So that whole thought that, oh, if you're a rich country, you're going to treat cancer better, you're going to get better outcomes, doesn't really hold. So what makes that difference? Is it down to the little things? Bring it down from that level to a national level. In 2017, there was a local study done comparing the breast cancer survival disparities between public and private hospitals in our middle-income country, which is Malaysia. And the uniqueness about this is that these two hospitals, public and private, actually sit in the same building. This is the University of Malaya Specialist Centre, which is the private centre, and the University of Malaya Medical Centre, which is the public centre. What the study showed is that the overall survival between the public aspect of the hospital and the private aspect of the hospital was significantly different. In the public, it was 71%, while in the private sector, it was about 87%. Why the vast difference? And it wasn't because of treatment disparities or demographic differences. But the real difference was in the public sector, the patients were older at presentation, they had more advanced cancers, and they were more likely to receive surgery and chemotherapy, but not radiotherapy. And you have to ask, why not radiotherapy? And it was basically because of the fear. Because of the fear of radiotherapy was one issue, so there was no compliance. But the second was because of logistics. Having to travel to the radiotherapy center, the incurred expenses in transportation, and absence for work, because for many of these people, they could not stop working because they weren't covered. While in the private sector, because they were more economically stable, open to second opinions, their fears were allayed and they carried on with treatment. If you take it to the next level, on an individual basis, patient A, a woman who went for regular screening, on her mammogram found to have microcalcifications, went on to do a biopsy, which found that she had early signs of cancer, did a lumpectomy, and went on tamoxifen. Patient B didn't have any regular screening, found a lump by herself. She went to her GP or her surgeon. They looked at her and said, "Oh, this is nothing to worry about. We'll just take out the lump." The lump was taken out, was sent for histopathology. It was found to be malignant. Surgical margins were not clear. At that point, mammogram had to be done. She then had to go for a mastectomy and lymph node clearance, had to go on to do chemotherapy and radiotherapy, and of course tamoxifen. The irony of this, those two people came from the same family, my family. Patient A was my mother. Patient B was my niece. The difference was they lived 40 kilometers apart from each other. The difference was that my mother was better educated than my niece was. That just happens just in the family itself. So you can imagine if you balloon that out to different countries, if you balloon that out to us in this room, if you look at the person next to you, if you look at the person at the next table, what outcomes are you going to have because of the disparities between us? So, what difference does a step make? From the examples I've shown you, it really shows that early detection makes a huge difference. Another local study which was done earlier this year shows that previous research on women who came to hospitals with breast cancer showed that the longer the distance they traveled, the higher the incidence of advanced cancers. And even if you adjusted for race, insurance, and education, that travel time raised the odds significantly in terms of how advanced that cancer is. That photo that you see up there is between KL Convention Center, which you'll be in tomorrow, and if you stay with us till Wednesday for the social evening, that is Sri Kakosa, where we're having the social evening. That is just 15 kilometers apart, a round trip. And that's what makes the difference in terms of how early you get diagnosed. The same study showed that Malaysia at the moment has subsidized mammograms, and the rate of women coming for the mammograms vary from 6.8% to 80%. And when you break it down, it comes down to distance. If you lived in an urban area, and you had to travel less than 40 kilometers, your rate for mammography was about 10.5 to about 32%. If you lived in a rural area, and you had to travel more than 45 kilometers, or even up to 340 kilometers, as some women do, the rate drops to less than 8%. However, hospital staff, the rate of doing a subsidized mammogram was 80%. So distance makes a huge difference. And it's just not in Malaysia. In the States, it showed that for free mammograms, if women had to travel more than 32 kilometers, the number of women who availed for that services dropped. In Australia, the drop was 3% per kilometer more that they had to travel to get a mammography done. And in Canada, if you had to travel after 25 kilometers to 50 kilometers, it decreased by 6.8%, and nearly 10% if you had to travel more than 75 kilometers. So the little thing as distance makes a huge difference in terms of whether or not you avail yourselves to mammography services or even treatment services. We've all heard this phrase, only the poor die of cancer. And in a certain way, we know it's not fully true, but it is true. We know from this morning that the burden of cancer and CDs will be borne by lower middle income countries who can least afford essential treatment, surgery and radiotherapy. And studies have shown that even though the cost of treatment in different countries might be different, so with trastuzumab, it is much higher in the US than it is in India. Even with that low cost in India, it doesn't translate into affordability. And there was a trial which showed that 99% of the women who were supposed to get the medication did not avail themselves to it because it was still not affordable. When you look at surgery, 80% of children diagnosed with cancer live in lower middle income countries. 20% of them need surgery, but most of them don't get surgery. And this adds on to the treatment disparities because survival rates in high-income countries for childhood cancer is about over 80%, but it drops to 20% in low-income countries because of access to treatment. The same with radiotherapy, where 40 to 60% globally have access. In the lower middle-income countries, it's because of resources. There are many countries in sub-Sahara who do not have radiotherapy services whatsoever because of the cost of radiotherapy. But there are countries in terms of high-income countries, such as Australia and Canada, where in sparsely remote populations, where the decreased population density doesn't justify complex health services, they don't get radiotherapy either. This is a study, the action study, the ASEAN Costs in Oncology by the George Institute, which examined the human cost of cancer across 8 countries in Southeast Asia to assess the impact of cancer on household economic well-being and patient survival and quality of life. It showed that 1 year after diagnosis, over 75% of patients experienced death or financial catastrophe. And 44% of them who started off with no financial hardship was pushed into some degree of hardship. And the factors in play here were that there were older patients, the income levels, especially those with low income levels in upper middle income countries were hardest hit. And the education levels, of course. And we talked a little bit about health insurance earlier on. It showed that with health insurance, with people without health insurance, there was a higher risk of financial catastrophe. There was also a higher risk of death relative to being alive and not experiencing financial catastrophe. So UHC plays a big part in this. So what do we need to do? What can we do? Baby steps make a difference. And it can make a difference in a positive manner. We know that treatment abandonment or failure to start potentially curative treatment is a phenomenon which is seen mostly exclusively in low middle income countries, both in adults and children. And it's a major cause of treatment failure. But there are success stories, and these success stories have been shown in childhood cancer. When we give targeted efforts to address the issue among patients and caregivers through establishment of psychosocial support, lodgings, transportation, food subsidies, setting up parents groups, it shows impact. They're simple to implement. There's been huge success stories in Guatemala. In a Vietnam hospital, the abandonment rates dropped from 50% to less than 1%, purely by setting up, 1, a parent group, and 2, providing transport for the children to hospital. Simple baby steps can make a difference. Integrating cancer into primary health care, as was mentioned earlier on in the last session, as Thailand has done, it would really impact in terms of prevention, the earlier detection of cancer, symptoms and sign recognition. We need to incorporate every single stakeholder into this fight against cancer. As I mentioned earlier, universal health coverage, what the action study showed. It showed that how insurance can make a difference in terms of financial catastrophe. And by just including the most common cancers, or some cancers, into the national UHC package, can make a difference between life and death for many, many people. WHO best buys. We know 8.2 million lives can be saved by 2030 in the low middle income countries. These are just some of the things that can be done. But these little steps, these baby steps, need to be placed coherently and strategically. We need to have an ecosystem in place. And very timely, last week in the Lancet Oncology, there's an article on the global analysis of national cancer control plans. And I quote from them, "There is an increasing global recognition that NCCPs are crucial to effectively addressing the cancer burden and to prioritize and coordinate programs." What it showed that countries with specific national cancer control plans versus those with just NCDs or health plans do better because they specify necessary policies to improve capacity and coverage and implementation. However, the catch is that even though many countries have national cancer control plans, many have insufficient detail in terms of the operational plans. So it showed that 79 countries mentioned strategy of implementation, but only 7% detail how it's going to be accomplished. Only 7%. There's no information about cost of the plan or how it will be budgeted. And here I look to my Malaysian table as well, because this is an issue that we face in Malaysia. Leaving no one behind is a core pillar of the SDGs. So I call on you all today. We need to move beyond crafting beautiful NCCP. We need to move beyond it to actually actioning on the costing and the budgeting of these plans so that we can implement them. So these baby steps that we can take will make a huge difference in addressing the disparities that we see in cancer today. Thank you.
Thank you so much, Dr. Saunthari. And now it's time to put you back in the good hands of Mr. Charles Goddard, who has an interview and then a panel and another interactive session. Round of applause for Mr. Charles Goddard. Doing a brilliant job today. Thank you.
Thank you very much, Yasmin. And I just want to echo Saunthari's thoughts there that brings us back this afternoon to the patient and to the outcomes that we're hoping to achieve through improved national cancer control. This afternoon, indeed, is about exactly that. What is the implementation around cancer control? What are the impacts we're looking for? What are the actions that are really driving some of these interesting impacts? And so we're going to be looking at a range of different examples from countries, from cities, indeed, and from other stakeholders, which those examples, I hope, will illustrate how these are creating important positive impacts under different circumstances. So I am going to I noticed this morning that there was a lot of really interesting and valuable insight from the floor. So we are going to make sure that we come down to the floor and give you the opportunity to talk about your own experiences and indeed your positive impacts or not positive, or negative impacts if you choose to as well as ask questions of the various panelists. So let's begin, shall we, with Dr. Susan Mercado, if I can invite her to the stage. Susan Mercado is, for the first interview, the Special Envoy of the President for Global Health Initiatives in the Republic of the Philippines. Susan, welcome. Thank you very much. Thank you. So the Philippines is moving to action, I hope, I'm sure you do too, in the enactment or the prospective enactment of legislation around cancer and cancer control. Could you start us off by talking a little bit about where that came from?
Do I need a mic?
Oh, sorry, yes.
Thank you. Yes, there is a draft. There is a draft bill. There is a bill that's pending in the Senate, and it's emanated from civil society groups. And we do have a very long history of civil society activism in this area. So it's not surprising that we've come to a point where we're now in the Senate, and there will be 3 or 4 more steps before this gets to the President.
So why cancer legislation? Why, we have, as I understand it, some legislation in other disease areas, but why cancer legislation?
Legislation provides backup for the executive branch of government in terms of budget. I think that is the most important point. It will lay out the principles for cancer control, and I think that the trick really to good legislation is for it to be more general and flexible, and not to tie down the hands of the executive branch of government, the Department of Health, to details. So I think this is something that will be negotiated as the hearings proceed on the bill. But legislation is useful because, one, it puts the agenda high in the minds of policymakers, and it can protect resources for public health.
So I suppose my obvious question from that is, what has been the experience with other legislation around other disease areas? Has that been a help in the Philippines to driving actions around those disease areas?
About 20 years ago, there was legislation on diabetes. Recently, there was legislation on tuberculosis. There was also legislation on childhood immunizations. And I think as far as public health programs are concerned, it is it's something you can stand by when you want to do more, when you want to ask for more money from government. If you do have legislation, then that's how it helps. But it is not a panacea. It will not result in outcomes unless you have resources that build capability to implement the law. So it could be beautifully written, and it could be gathering dust on a shelf. That's the extreme. The other side of it could be you could take it and you can use it to mobilize resources and to get people to do things.
Well, let's come back to that resource issue because I think it's a really important one in a second. But let's just talk about the relationship between the National Cancer Program at the moment that's sitting there, which is actually, when you read it on paper, it's a pretty good one, and the legislation itself. And you say they're complementary in that sense, but are you going to have kind of institutional challenges around implementation if the legislation goes through?
Oh, absolutely, absolutely. I mean, there is always a huge disconnect between policy and program implementation. We know that. In all public health programs, this is the case. Where the rubber hits the road is in primary health care, delivery, first point of contact, and the ability of a very complex health system to respond to a sea of demand. It's a sea of demand. It's endless. There are so many types of cancers. So many people are affected. We don't even have the fundamental surveillance and epidemiologic infrastructure to capture what is happening in terms of cancer. So there is a lot that needs to be done in terms of the public health program infrastructure, and that is not unique to cancer. This is true for all non-communicable diseases. So even if you legislate, and we know that there are gaps, I think what we're really missing in this big piece is how do we develop national program managers in non-communicable disease. It's quite different from communicable disease. We've evolved over the years very good program managers in tuberculosis, in immunization, and that takes time. But when it comes to non-communicable disease, you're dealing with two different parameters that you don't see in infectious disease. One is chronicity, that you're going to deal with the patients year in, year out, that your incidence and your prevalence are going to be intertwined because the disease doesn't go away. It's not like measles, you get it and you don't have it anymore. So chronicity is one. The second is, and I was just reading on a very interesting initiative in the United States called precision medicine, and applying that to public health, which is getting the right treatment to the right person. If you extrapolate that and think about getting the right intervention to the right population, then we have to think of the genetics. We have to think about whether or not cancer drugs that are available are actually effective for the populations that we're giving them to. And we're seeing in the area of genetics that it's not the same across populations and across countries. So there's specificity that is related to hereditary factors that we don't see in infectious disease. So these two areas make it a little bit more complicated and a little bit more difficult to manage a prevention and control program and to move from control to elimination or eradication. It's more complex in non-communicable disease, and I think unless we start investing on strong leadership programs for public health managers to handle cancers and different types of cancers, even if you have law and even if you have a national program, we're not going to crunch the numbers the way we'd like to crunch them.
So you talk about this need for NCD program managers, and
yes.
I wonder to what extent, and one of the conversations this morning was about the relationship between NCDs and NCD control generally and individual NCDs and the management overall, the strategic vision that sits around NCDs and cancer. How do you think that operates? Because we are now seeing, we're in a period of growing multimorbidity. We're seeing lots of different diseases come to individuals. What do you think is the is there an overarching vision now for NCDs that begins to address that in a more strategic way, in addition to thinking about how cancer fits in there?
I think this is going to be a continuing discourse. Do we look at NCDs in general because they are interrelated? Yeah. So diabetes comes with hypertension, cancer comes with infection, so on and so forth. So there's going to be that continuing discourse on do you approach it as a whole or do you dissect it by disease? And I think I'm a practical person. In my view, what we need to do is to think about problem solving. There's a problem in front of you, how do you solve it? And it varies from country to country. So it's very difficult to say that one can come up with a very comprehensive NCD program without picking out where you're going to make an impact or where you're going to make a difference. So the question is, where do you have modifiable risk factors and can you modify them? And what is the cost of doing that? And that's where I think we begin to make decisions on looking at multiple risk factors or just one risk factor at a time, or multiple diseases or just one disease at a time. So it's got to be approached from the perspective of what's happening in a country and what's the capability to do something about it. So that discourse is going to continue. I don't think it's going to go away. But ultimately, I think we will go into individual diseases. In the same way that we have done this in communicable disease, it's inevitable that you're going to think about breast cancer, you're going to think about cervical cancer. It's going to go in that direction.
And there's going to be elements of the plan, the NCCP, that is going to be addressing single disease areas as well, like breast cancer, I think. Yes. Just to come back to this question of institutional barriers to the implementation of a plan like this. I mean, you spoke about the barriers that are represented by, not enough expertise around particular NCD program management areas. What about the relationship between those that started this bill, effectively, which was a group of advocates and patient groups, and their relationship and the relationship of the bill to those that are going to have to implement it in the Ministry of Health? Is there some sort of tension that you see there between, in the implementation of this, because it didn't actually arise from the ministry itself, it arose from society and from the ground up?
I would say that in the realm of NCDs, and we just heard something about, we just heard a very beautiful presentation on inequities. Your real barrier is indifference. And the indifference is social in nature. Government being just one player in society, it's social in nature. And sometimes, unless you have leaders who are touched by cancer, they're indifferent. They don't realize what kind of suffering a family goes through. And I think that and that's why you would have a huge support coming from civil society, from survivors, and so on. I was at the Lincoln Memorial Center 2 weeks ago where they had this Lights of Hope ceremony with a bag with the name of a loved one with cancer that they put around the reflection pool, and it was 33,000. And this was from all the states of the U.S. I was invited by the Guam Cancer Coalition, and they brought in 300 bags made by 300 families. And that effort was directed towards one thing. It was to remind policymakers to put in, not to forget, to put in money for cancer control programs. So going into, is there a difference between how civil society does, what civil society sees and how government sees it? Of course, because government has to deal with multiple interests and multiple concerns, and this is very specific. But having the right numbers and showing the government that this is in fact a huge epidemic causing so much suffering is part of the bill. That's part of the legislative process.
Well, you raised this issue of the funding and the need. I mean, I suppose part of the focus of the bill is to institutionalize the funding for it. How do you see that playing out? I mean, obviously we've got to get through the Senate, we've got to get the bill out there, and then there's going to be a series of discussions, if it passes, about how effectively to budget it and fund it. How is that going to play out?
Well, yes, this is the thing. I've been studying the bill, and I think that's where we have to make. That's what we need to fight for, because the budget is the highest form of policy. That's the highest form of policy. We can have policy that talks about general principles, but unless you have funds committed for a particular program, then it's nothing. It's just, this is what we believe, and so on and so forth. Now, unfortunately, in the current version of the bill, I have not seen a good way of calculating how much money is going to go into the program. And I think that's something that the World Health Organization needs to address, to start looking at how does one calculate the costs of a national program. And then it goes back to, if you had a good program manager with X amount of money, then how would that person use that money? So this is an area that requires more technical input I think, more study. And currently, because we don't have the numbers, we have estimates. I think globally that's the situation. We have estimates. We don't know because so many poor people develop cancer and they're not recorded. So I think this is an area where we need more support and where more international collaboration will be very useful.
There are 3 or 4 key areas that the bill is going to sort of address in a very broad way. As you say, it's not the National Cancer Control Program that's looking in a detailed way. Strengthening of cancer information, registries, institutionalizing the funding, strengthening potentially education and prevention, which I think must be a really important part of it, and screening programs at the moment. The National Cancer Control Program, one of the things that Saunthari brought up earlier was that the study that has just been done in The Lancet and by UICC partly was that the finding was that national plans had really insufficient detail to operationalize themselves. And I wonder whether you feel that, you know, despite there being legislation there, that the plans aren't still operable, and that, you know, there's so many gaps and so many shortcomings in the present National Cancer Control Program, despite being well written, that will still be a big challenge to implement.
There are choices that we will need to make to be strategic and to develop the experience in controlling and modifying disease outcomes. So while there is a huge demand to address everything at high level at the same time, it's not feasible. So we will have to make choices. And these choices have to be based on evidence. We've got to look at cost effectiveness. As I said, we've got to look at what's coming out of the field of precision medicine, what are the right medications for the right population groups, and so on and so forth. So my sense is that we will have to select where we can make a difference. Not that we want to neglect other types of cancer, but this is about being realistic in terms of building capability. So once we have, let's say, good capability on breast cancer, cervical cancer, and childhood cancers, then I think it becomes easier to bring in liver cancer and lung cancer and so on and so forth. But you've got to start somewhere and develop success somewhere where good outcomes are already known and medications are available.
So something wider, slightly wider, but necessarily part of the bill will be this question of equity of access. I mean, affordability, ensuring that people do get access. This is a central sort of plank of what we're discussing today. How do you think, beyond the bill itself, the equity of access issue has now been addressed in the Philippines?
Well, the main institution that can change this in our country is the Philippine Health Insurance Corporation. They have the potential to provide medication support to anyone, anywhere, from any medical center. But what we see in the Z package, this is what they call this new support, which we didn't have 10, 15 years ago. So it's a big thing that you could charge a certain percentage of cancer care to health insurance, but it's a very small amount of money. Yeah. So what we need to see is probably bigger investments on pre-hospital care, screening, and I would say, you know, just simple history taking and looking at families at risk. Going back to that genetic thing again. I mean, I don't mean to diminish the social determinants of health in relation to cancer, but we have to really internalize the fact that cancer runs in families, and just the simple act of making a family tree and understanding if you have cancer running in the family is something that could help the Philippine Health Insurance Corporation determine risk. Now, of course, in other countries, there's a lot of work done on biomarkers, and this is another tool that could potentially change the game if it becomes cheaper for countries to use. So I would say, you know, inequity, it could be addressed through the Philippine Health Insurance Corporation, but there are shifts that are needed, and the shift has to be in the area of early detection and screening.
Susan, this is fascinating. I just want to thank you very much for a wonderful discussion. But before I end it, just one final question. The President, is he going to be behind this when the legislation comes through to him and he puts his pencil, he puts his pen mark on it? Do you think he'll be behind it? Do you think he'll really get behind it?
A lot of people don't know that for many, many years, the President has a private charity that he's supporting for children with leukemia. And when he visits these children, he is in tears. I mean, for those of you who know our President, he's a tough guy.
I didn't want to mention that, but...
He's quite tough. And, but being with these kids brings him to tears. So I would think there's a very strong chance that he's going to support this.
I hope so. Well, thank you, Susan, very much.
Thank you very much.
Join me thanking Susan. Thank you. So let me, from there, move to expand our panel and invite up to the stage, if I could please, our other three panelists. The Mayor of Kumasi, Ghana, Osei Assibey Antwi, Kolleen Kennedy, the President of Oncology Systems at Varian, and Lynda Thomas, the CEO of MacMillan Cancer Support. Do please join me. Thank you. Nice to see you. Do please join. Very nice. Would you like to sit here? Thank you. We'll do that. Very British about it. Well, thank you, everybody. And I thought we would start. I mean, this is the sort of part of the session where we get an opportunity, I think, to really explore how different countries, different stakeholders, and in your case, different cities are beginning to address the cancer challenge and to have a positive impact. And I thought I'd start off with you, Mayor, with just asking you to give us a sense of how it's going. You were chosen as part of the City Can process, and now where are you in this? How are you beginning to address the challenge of improving cancer control in the city?
Thank you very much.
Could you tell us a little bit about Kumasi first, because I don't know very much, but I'm sure not many people know very much about Kumasi.
Yeah, thank you very much. I come with greetings from Ghana, and most especially from Ashanti region. And the Ashanti region is a kingdom, and it's under the kingdom that I found Kumasi. And the kingdom is the great kingdom with one king controlling the whole kingdom. And the capital of that kingdom is Kumasi, which is where I am the Metropolitan Chief Executive. The kingdom is 345 years old, more older than the country Ghana. And with regard to the cancer project, it was last year that we had opportunity of being invited to Mexico. That was the place where my city was named as the 4th learning city. And it was a very important news to me and to the nation as a whole. So immediately we went back, and fortunately for us, in February this year, we got the whole project inaugurated. And immediately after the inauguration, we put it on us that how do we get the buy-in of the major stakeholders. So the first thing that we did was to present the whole package to the knowledge of the President. So myself, the regional minister, and the Minister of Health went and introduced the cancer project to the President. And the President actually bought into it and immediately charged the Minister for Health to take the challenge up. And the President insisted that the Minister of Health should have one of his immediate bosses to be part of the team. So now I have on my committee the whole country head of oncologists sitting on the committee that is managing cancer from the city. So from there, the issue was with decentralization. When we talk of decentralization, every region has a regional minister. And the regional minister is working with 43 district assemblies, making out from the metro, the municipal, and the district. So the next thing that I did was to lobby the regional minister for me to have access to all the chief executives from the 43 administrative districts. So they all came together, and I had opportunity of presenting the cancer project to them. I am more passionate about it because I'm a victim of it. I lost my mother out of cancer. So anything about cancer, I want to fight it with all my health. So that is the way we started. And from there, after the executive committee was put up, it afforded us the opportunity of going further by bringing on board all major stakeholders. So now we have a larger body working on the project. We have broken them down into several unit committees, with others working on how we can fashion out the system which is going to help us in the area of early detection. We have another team that is also working out on how we can build on our data. We have another team that is also working on how we can disseminate the information. Now I sit here and I can confidently say the king of the kingdom has also bought into it. Because just about a month ago, the king, who normally has a larger team under him, because he has more than 45 paramount chiefs working under him, has also selected one of his paramount chiefs to come and work with us. So this is the way we started the whole process.
Can I just ask you, how big is the city of, I should have looked at this before, but how big is the city of Kumasi? And
the city of Kumasi on every single day has a population of 3 million. 3 million,
yeah. So, and the cancer universe or ecosystem in Kumasi prior to you beginning this program was fairly, fairly fragile.
What I will say is that before this project started, even though there was a small advocacy somewhere, but you see, the stakeholders were fighting the cause disjointedly, but they were not coming together. Right. So it was after our inauguration that we created a platform for the first time for all the major stakeholders to converge and discuss. And so now I can say that it was because of this project which has given us and which has charted a platform for a common goal.
So one of the really important, I suppose, goals of the CityCan program is for it to act as a kind of, or those cities that are chosen to act as a kind of Trojan horse for the development or the acceleration of cancer control within countries and to have a profound impact on the national cancer ecosystem. You mentioned that you've got the president on board, you mentioned that a number of the Ministry of Health is on board. I mean, do you see some sort of immediate benefits from being chosen as a city for the kind of impetus and energy that's been built around cancer control in Ghana?
Well, I see this project and I see UICC as having led a very good cause for bringing the people who are suffering closer to the expert who can help them. Today I came here to this conference with the Metropolitan Health Director, but previously when I was invited to Mexico, I went there with my secretary. What is the difference? The difference is that now, as the manager of the city, I have gotten the knowledge of cancer and how a treatment can be fashioned out. So now I can say confidently that what the Metropolitan Health Director buying into the project, he is a captain when it comes to the health delivery in my kingdom. And there I know every week she has a session with all the managers of the hospital at her department. So I'd had a discussion with her a week ago about what she is going to do to make sure that we accelerate the cancer, the fight for the patients who haven't gotten the knowledge to come closer to where they can get their help from. And she came out with a very fantastic idea. And the idea is that now she has decreed that every 2 weeks, all the directorate, that is all the doctors coming from the various hospitals, will have to come to her for discussion on the cancer issue. So this is a step which is also going to enhance it. And it was after this project that the media were also brought on board, because now in my part of the world, the media has knowledge about the project.
Very important, I might say so, coming from the media myself. One of the obvious challenges that I think the city program faces, and you're now in the planning phase of it, as I understand, so there will be then, in a year's time, an implementation of that. The thought around the City Can program is not just that it will accelerate the national program, but that it will draw in a whole range of new stakeholders or partners into the process. And I think it's the building of that set of partnerships that's really, really important, but probably also quite challenging. How do you see, are you beginning that process now, and how do you see the sort of the wide group of potential partnerships evolving around Kumasi?
It has really started because the fight against cancer in my city was started by some advocacy groups. So with this platform now, we have brought them together. So it's not only the state functions or the state bodies that are fighting it, but now the civil society are on board, as well as the religious groups, the traditional authorities, and the government. So we have started bringing all of them on board, because the fight has to be, you have to chart the court on a holistic manner. And that is exactly what we started doing by bringing all stakeholders on board.
I want to just actually throw it very quickly to Kolleen here, because I know you're a partner in the City Can Challenge and that process. And how do you see the role of the private sector, particularly in supporting the city programs, and what role do you specifically see for the private sector to help in this, and how are you going about it?
No, first of all, if I may, this is my first World Cancer Congress, and I'm thrilled to be here. And as you all saw this morning, I have the honor of being on the inaugural board for the City Cancer Challenge. So I will be on a tremendous learning curve over the next few months. You know, when we think about the industrial side and what role we can play in the City Cancer Challenge, I'll just take a step back for a moment and maybe talk about radiation oncology, which is my area of expertise. I've been in the field for 40 years now, starting 10 years in the clinic and 30 years on the side of industry. And I've had the, I'll say, distinct pleasure of spending the last 2 decades at a company called Varian, the world's leading global supplier of radiation oncology. My view as we look at multi-sectorial support and contribution for the City Cancer Challenge is that radiation therapy generally is not at the front of the conversation. And the view is that with the traditional pillars of cancer care, med-onc, surg-onc, and rad-onc, we need to be able to look forward successfully with these national cancer programs and to find a way to implement across all the different stakeholders credible actions that are appropriately resourced. From an industry perspective, we have been very successful in looking at alternative financing models. One example will be a managed equipment services approach, specifically focusing on radiation oncology, because I do know that the perception is that radiation oncology is tremendously expensive upfront because of the CapEx investment, whether it's the equipment or building of vaults. We do recognize that. With this approach, like an MES, for example, we're able to put together a very structured program over a period of time, and we've done this quite successfully with the UK, the NHS Trust, for example, very, very well. A very well-known, understood operational model that includes equipment, it includes resources and funding for the facility itself, as well as training and education. And everything is kept evergreen. So as technologies advance, as healthcare providers transition in and out of a particular institution, we're able to ensure that the patient quality of care continues to be at standards and even exceeding standards over time. So as we think about the City Cancer Challenge, I think the technologies that are available today that make radiation therapy a critical part of a successful multimodality treatment regimen is one area that we need to make sure we don't forget. And number two, looking at alternative financing models so that radiation therapy can be considered as part of an overall national cancer program, and within the cities themselves, how we can move forward successfully.
So there was a very good report in the Lancet Oncology Commission on radiotherapy. I wonder if you just tell us what the case for radiotherapy is in a nutshell, just so that we sort of get a sense of why it's that important.
It was terrific seminal work, I have to say, and I think there's general recognition around the globe that 50 to 60% of all cancer patients can benefit significantly from radiation oncology. And the work that was done by the Global Task Force on Radiation Cancer Control under the auspices and guidance of the UICC demonstrated very clearly that a significant number of linear accelerators are needed around the world to address the global cancer burden as projected by 2030. An investment of $40 billion, which I know sounds significant, however, by 2030 would result in an overall net economic savings of $280 billion. So medical physicists by training, you don't need to have an economics degree to be able to understand the return on investment of radiation oncology. And I think that that Green Journal publication, the Lancet Oncology Journal publication, was very impactful. For the first time ever, practitioners of radiation therapy industry have been able to sit down with government officials, and including not only the Minister of Health, who I think saw the value of RT, but ministers of finance, so that they could be able to take a look at the economic benefit overall. We have not been able to articulate successfully before that publication and become advocates for the discipline that we would bring to patient care from an RT perspective. And I think there's terrific work done by that, and I'll put one more number out there, and that is that 27 million life years saved with that level of investment in radiation therapy by 2030.
And of course, I think the point of the Lancet Oncology Commission was not, so much to simply promote radiation therapy. It was to say, well, actually, radiation therapy in conjunction with surgery and other treatments would be fundamental. Otherwise, we're not really bringing the ecosystem of cancer.
Absolutely, Charles. And I think it's just that when you look at the referral patterns for most cancer patients, that patient is brought forth generally through the medical oncology channel. And there's terrific partnering from a multimodality perspective for all different disciplines to be represented well.
Can you, just to come to that sort of sense of partnering, I wonder if you could just unpick for us one example of how Varian is partnering in a country, and what are the sort of, I suppose, what are the elements of that partnership, and why are those partnerships now becoming more essential if poor countries want to buy and invest in this kind of equipment?
Yeah, and
I'm not making an advertisement for Varian here, but I just want to just sort of understand what it is that partnership looks like.
Mm-hmm. In each country, the situation is different, and there are very comprehensive cancer programs. There are countries in the world where they have absolutely no radiation therapy at all, and we do know with low middle-income countries, 10% or less access to this critical life-saving technology. Our view is that we can provide the best technology, the best medical devices and software possible from a radiation RT perspective, and we believe that we do. But one of the things that we have learned over time in working with government entities is that the training and education is equally as important. These are sophisticated pieces of equipment. There is a significant investment that needs to be made around getting skilled human capital, whether it's clinicians, medical physicists, radiographers. And we have been investing significantly in a program called Access to Care for several years now. And what we do is partner with thought leaders around the world. For example, we just put in place a short while ago with the University of Cape Town, a training and education program around radiation therapy that serves all of sub-Saharan Africa. We've done the same thing in Vietnam, partnering with Ho Chi Minh Hospital. And again, what we see is that we can train how to use our equipment safely and effectively, but to bring that skilled capital from a human capacity perspective up to speed successfully, we need to partner with thought leaders around the world to help train the physicians on how to do high-quality radiation therapy, medical physicists, how to make sure the equipment is being operated safely and effectively.
So with the Cities program, and just to sort of end this little segment, but just with the Cities program, where are you working together with each of the cities that have been identified in the CityCan program? Is that part of the remit that you have there?
That will be the intention. I think we're just getting ramped up in terms of that particular aspect of me being on the board and having the opportunity to sit down with the different cities and learn about the progress thus far.
I want to stay very briefly on the cities challenge, because I want to bring in, if I can, our friends from Myanmar, who also have a city, Yangon, the capital city, which has been designated as one of the CityCan cities. And just to sort of, if you can, give us a sense of, A, where you are in the cities process. If you could get a microphone down to the back, please. If you could just put your hand up, Soang. And just get a sense of where you are in the cities program and how you expect it to be. Can we get a microphone down here, please? You can run it across. There we go. We've got a runner at the back. I think just as we've got our minds on this program, Soang, if you could just tell us where you are. And Kerry, I don't know if you're still here, but I might have to come down to you as well. But
thank you, Charles. As Royal Highness Princess Tina pointed out, we are one of the 4 key learning cities, and we were adopted just before Kumasi. So we are about a year older than Kumasi, and we are at the stage of planning at the moment. And we are over a year into this planning stage. And we have divided our activity into 4 groups, main groups: basic cancer services, management of cancer services, quality control, and community access and comprehensive care. And in these big 4 categories, we have divided into 16 activity plans, and we are trying to sort out these activity plans and also detailed work plans. And so after this, we are going to come up with cluster plan at the end of 2 years period. And following that, the remaining 3 years will be more or less on our own, of course, helped by UICC and other international stakeholders and collaborators to implement that plan ourselves. So although we are at the planning stage, some components are being implemented if they are feasible. Like in pathology, we are already in contact with American Society of Clinical Pathology. They are coming to us this or next month for site visit and QC workshop, and we are studying to implement in that area as well. So in addition to this CCAN project, we have 2 main projects. One is NCCP. We started about 3 years ago at the costing stage as well. And the third one is UNGJB Cervical Cancer Plan. So these 3 major programs are going in parallel. What we want to do is we want to sort of compile all the resources and into one main project. So we can share the resources between the projects so that there will be no wastage in terms of resources, both material and human resources as well. What I find at the moment, the most important thing to be successful for this project is, one is political will. Will in terms, not only in terms of words, but in terms of action as well. Will in words, nothing. And when I talk in terms as well, I mean they must allocate some resource, substantial resource to the project as well. So as we used to say, A, B, C, A, what you will contribute to yourself, to your own country. And B, what are the potential donors, and C, what is the cap. So if our government must be able to, cannot contribute something to the project, it's not reasonable to ask for help from other donors. So it is very important that we contribute ourselves. That is one thing which is important. The second important thing is what I find is collaboration among stakeholders. Like Dr. Antwi has pointed out, we must have a good single platform with a common goal towards which each and every stakeholders go. Otherwise, if we are working in a fragmented manner, we will never get anywhere. So that is exactly what's happening at the moment. We are trying to sort of collaborate and coordinate all the stakeholders, both in public and private settings together. That is the only way to go ahead and to be successful.
Thank you very much. I think that's an interesting update and slightly different stages that you're at, and I can see that you're going to be coming to this question of how do you manage the stakeholders and bring them in a little bit more quickly than Kumasi is, but nevertheless very interesting. Carrie, I'm not going to ask you to come in right at the moment, but perhaps a little bit later, just an update on where the whole program is from UICC point of view. But, Lynda, let's, sorry, we're getting around to you eventually. I mean, you're coming at the whole cancer question from a support point of view and from an advocacy point of view. I really think it would be important, because one of the things that I think is special about, say, the Philippines has been that advocacy has been so fundamental to the pushing of the cancer agenda. And I think one of the challenges for many other countries in Asia, and I'm sure elsewhere, is that advocacy is much, much more difficult. And that governments don't always listen, or don't always want to listen, or refuse, even reject advocacy. Tell us a little bit about your world and where advocacy is important.
Yeah, sure. I mean, it has been an absolutely fascinating day, and thank you to everybody for speaking so far. And I guess I'm coming at it from a Northern European's perspective, from a small but slightly complicated country. If I just said Brexit, we like to make things very difficult for ourselves, where actually I'm thinking, why do we have the problems that we actually have, when actually I'm thinking about how complicated your lives are in the different countries. But I think we have a lot of the number of similar issues, actually, and from an advocacy perspective, we've got a mature setup in the UK. I mean, I'm here from MacMillan. There are colleagues in the room from Cancer Research UK. We work very closely together, and we hold the government to account for what happens in the UK to cancer patients. And we're coming at it from a perspective where we have a cancer plan, 97 recommendations, costed, and an implementation plan, but it still doesn't make it easy, actually. So it's interesting how it can still be very complicated. We have a huge issue in the UK, which I think affects the rest of the world as well, around the cancer workforce. And one of our big campaigning themes would be, where are the doctors and where are the nurses that are going to be treating patients in the future? Which seems unimaginable given that we have prevalence figures that take us to 2040. How can we be in that situation? But we are in that situation. And what the UK does very nicely is it steals and borrows from other countries. So while we might have a crisis, we borrow other people's specialists, which then leaves other countries with huge problems themselves to fill. And I think from the perspective of us as charities, the difficult thing at the moment that's happening in the UK is we are gap filling. So we're having to fill gaps that are left by the statutory sector when our donors really want us to be adding value rather than gap filling. And I guess just finally what I wanted to say was, in every other part of our lives, the customer rules everything. So we as consumers rule everything with our banks, our building societies, who we buy our mobile phones from. But health is completely different. And there's something here about we need to understand what our customers are going to need from us in the future and then organise ourselves around them rather than saying, you fit into what we have to offer. And that, I think, is a challenge for all of us, and it's a challenge for our systems. But the big thing that I keep hearing going forward is personalisation. And whether that is, I want access to the drugs that will help me. They might not help you, but they will help me. Therefore, I want access to them wherever I live. And even in the UK, we have huge variations around things like that. I want access to the best care team as a patient, not the traditional model which says the doctor dominates the care team. I'm happy to be supported by a trained volunteer if that person is the best person. So I think it is now, let's turn it on its head. And that probably is the only way that cancer care is going to be affordable in the future. In the UK, anyone born after 1960 has a 1 in 2 chance of developing cancer. So it's going to affect all of us, and the only way we're going to be able to cope with those pressures is to look at a different model.
Susan, I see you nodding in agreement with a number of these things. I wonder if you would like to just come in.
Well, you know, all health systems, whether in rich countries, poor countries, big ones, small ones, health human resources is the challenge. That's the challenge we have because we are a, human resource intensive undertaking. Health cannot be done without people. And I think cancer is going to revolutionize primary health care. It's going to be the thing that's going to change the way primary healthcare is organized. And this means that we in the health sector need to be ready to evolve new types of professionals who are not necessarily doctors, who are able to do the early stuff effectively and in a timely manner. And I agree with you completely. I think we can see where it's going. We know what the projections are. And we have to reshape ourselves now. The sector needs to reshape now to be able to respond. I mean, we're already late. We are already late. So the sooner we're able to do that, again, I'll go back to the role of the World Health Organization in this. The World Health Organization has to be, more proactive, has to be bold, and it has to start gathering minds around the table to think about what are the new healthcare workers going to do to help people now and in the future.
I agree. The bold message, the message to be more courageous and brave, is one that I think comes across the entire day that we've been speaking about this. Can I just come back, Lynda, to this question of the balance between gap filling and, influencing policy? And I assume that MacMillan was set up to do the latter, not the former. I may or may not be right, but I'm just. What is that balance, and why is it? Why are you now finding yourself, to the chagrin of your funders, doing more gap filling than you'd wanted?
I think to a certain extent, we've always tried to be there for whatever the patients need from us. So in many ways, we do what we did 100 years ago when we were set up, providing high quality information, healthcare professionals supporting people in their homes and in hospital. I just think the difference is the rising incidence of cancer has meant that we're having to see and be with more patients on a daily basis. Cancer is becoming so much more complicated than it used to be, and I've only been in this field for 20 years, so less than other people. But actually, in the old days, it was a much purer form of looking after patients because there was only 1 or 2 things that were going to happen to them. Now it's become so much more complicated and different people require different things, and a huge rise in the number of people living for decades with cancer that can be treated but that can't ultimately be cured, who have a huge range of problems. So we've got an increased demand and we've got increased complexity, which makes our jobs in many ways so much more rewarding, but also harder as well. And I think the system, I heard from my colleague that we've all been late to the party on this one, and systems have been very late to the party, and which has left us as an NGO with no option but to go in and do the gap filling, because we want to make sure that today's patient receives the care and help that they need, rather than saying, well, in 10 years' time you can get it when we've done the influencing. But there's no question, influencing system change is much more effective than delivering one-on-one interventions, and we have to do both of those things. But just to give you examples, when MacMillan does a whole range of things, like we do grants for patients. So these might be patients who have an emergency need, so they'll be receiving cancer treatment. And we've heard today, lots of patients when they have cancer treatment are financially disadvantaged, and that is exactly the same in the UK as everywhere else. So we might get a request for £200 or £300 for a vital piece of equipment from a member of the public. And we've always done that, but increasingly now we are using advocacy to do that. So to work with the people who set the benefit system in this country to make sure it's more equitable and fairer and people can access it. to work with organisations like banks and building societies so that we are not providing the cash for patients, but banks are providing the financial support. So forging new partnerships as well. So I think advocacy is not just about working with governments, it's actually working with a whole variety of partners, whether they be financial institutions around people's finances, insurance companies around why can't people with cancer get insurance, especially if there's no need for them to not be able to get insurance. Working with retailers in the UK, for example, we do a lot of work with retailers and actually really influencing on a much wider sphere now than we used to do.
I think that's really fascinating, is that whole ecosystem of the people that you want to influence has massively increased, hasn't it, over the not so very recent past. And you talk a little bit about living with cancer as well, and I mean, I think the context of this conversation so far today has been how to address it in the first place, but increasingly, as you say, living with cancer is a reality, and changing behaviors around that. I mean, we did a study, I'm not sure if MacMillan was involved in it, but I think somebody was interviewed from MacMillan around breast cancer in Europe and breast cancer in the workplace. For those that had been diagnosed with breast cancer, what was the attitude and behavior of their employers and other employees around them? And then survivorship, those that had come through it and who had to then engage back in their workplace. And the difficulties, the huge difficulties that they face. This is a really an important and growing area, it seems to me, of cancer advocacy, isn't it?
Yeah, so cancer and work is a major theme now in the UK. We know that patients, when they get a cancer diagnosis, want to stay in work and want to be able to go back to work. Not just because it matters financially, but it actually really matters to you as a person. It's often your identity. And we never want to get to the stage where people are not telling their employer about a cancer diagnosis because they're worried about their job prospects. So we have done a lot of work around that. I think it would be fair to say that people of working age with cancer are some of the most disadvantaged groups. It's almost like it's a double whammy that nobody's expecting you to get cancer at that age. Your peer group is not so good around you, and you may be supporting family members if you've got children and things like that. So it's actually much harder. So I think you would have talked to us about the working with cancer issue, because we have developed a toolkit for employers which helps people support employees when they have a cancer diagnosis. In reality, it's about having a good conversation. So if a member of my team is just diagnosed with cancer, I need to sit down with that person and say, what do you want over the next 9 months? What do you want over the next few years? Do you want to carry on working? And then putting in place the measures to make sure that that can happen. And if that can't happen, making sure that people can take time off and then come back to work. More and more people are going to be living much longer with cancer, so we need to make sure that we get that right for people, and responding to the ways that people want to live. And one of the things we've been doing at MacMillan is talking about quality of life. So we all know that surviving is really, really important, and governments tend to measure things in how many people survived 5 years after a cancer diagnosis or 10 years. Measuring something like how well are people surviving is a completely different matter. But if you ask the person, that will be the most important thing to them. So asking somebody, what do you want out of the rest of your life? I think particularly for patients who have one or more other conditions. So if you're a patient with dementia, cancer is probably not your biggest worry, actually. Yeah. So there needs to be a conversation about the type of treatment that is relevant for you and what should you be having. So it's managing it in a completely different way.
Right, I thank you for all of those thoughts and comments. I'm going to throw it down to, well, I'm going to ask everybody, as we did before, just to take 5 minutes around your own tables, just to sort of consider some of the things that have been said, and hopefully think about whether you'd like to contribute and you'd like to share some of the thoughts that you have, particularly some of the experiences that you have from all sorts of different perspectives. Can I just leave it around the tables first, and then I'll come to you immediately after sewing? Yep. So let's take 5 minutes. We'll turn our mics off, and then we'll come back to you straight afterwards. Thanks. Well, ladies and gentlemen, let's come down to the floor. I'm going to start with the man with the hand up there, if I can, and then I'm going to come to Afira down there, who's in the red, who I'm sorry I missed earlier. I didn't see you, but if we could start with you. Yeah, thank you.
Okay, thank you. I'm Wendu Bakala from Matthias Wandi Ethiopia Cancer Society from Ethiopia. I think when it comes to National Cancer Control Plan, we have a very good cost-effective experience. I remember it was in 2014 in World Cancer Leader Summit in Cape Town. I emotionally presented why the place where we live should determine whether we survive. So then I emotionally presented a call for partners to support us, Ethiopians, to develop National Cancer Control Plan. Then immediately I was approached by Pink Ribbon, Red Ribbon from George Bush Foundation and NIH. George Bush Foundation, they gave us support, financial support, and which we successfully recruited and seconded highly qualified professionals to the Ministry of Health. I tell you, it is unusual for local NGO like us to recruit and second highly qualified professionals to the ministry. So then we successfully got National Cancer Control Plan with a budget. In Africa, so many people talk about National Cancer Control Plan without involving the ministry and without the ministry holding the driving seat and without a budget. Nowadays, now we have procured 6 radiotherapy machines. The government already built 5 cancer centers, thousands of cryotherapy machines being procured and what have you. So the involvement is very high, almost 30% of our National Cancer Control Plan being expended. My worry is the Pink Ribbon, Red Ribbon program, they told us that they will end their support on coming December. I'm a little bit frustrated because the Minister of Health is not in a position to successfully implement the National Cancer Control Plan. We have done a midterm evaluation. The implementation is very good. I am this time also calling upon friends to help us continue the support we are giving to the ministry so that we successfully implement the National Cancer Control Plan. For example, if I tell you, I fully agree with our friend from India, the radiotherapy machines being implemented in 5 regional university hospitals, but the human resource is not there. Now our government is now trying to recruit people from India, Cuba, and what have you. So please, if those of you who are in a position to help, please help us to continue our support to the ministry so that we can continue making a difference in Ethiopia. Thank you.
Thank you very much. Behind you, I'm going to go to Afira first. Afira.
Thank you. Thanks,
sorry, this is not a manel, i.e. a panel full of men. That's this is a more balanced one.
My first comment from the morning is now moot, but it was a rhetorical question about an all-male panel. So, thank you. No, there seems to be a few assumptions that have sort of gone unchallenged from the morning session. Number one, that there will never be enough funding in the public system in LMIC to provide adequate coverage for cancer services. And number two, this assumption that we must therefore turn to industry, in particular pharma, to support cancer care and control. And number three, public-private partnerships are by definition a good thing. So what about regulatory oversight, accountability, and evidence? And it's kind of a 3-part question. Thanks. And the hashtag for this, for those of you on Twitter, are thinking inside the box.
So I wonder if you'd like to, well, pick up one or two of those issues. Public-private partnerships are not necessarily all good. Maybe I come to you first, Kolleen, just to sort of answer that question.
Yeah, you know, and I will say there are many different permutations of public-private partnerships, and I think that they can be ripe with opportunities for poor implementation and poor execution. That being said, if you have the right people at the table, all stakeholders represented, I think there is huge opportunities to leverage those types of models successfully to bring better cancer care to patients who are very much in dire need. In terms of how do we do this well and involve industry successfully, I think that it's critically important that we have a multi-sectorial approach to truly go after this. I think that every stakeholder has an obligation to work together to find a way to bring better cancer care for patients around the world. I don't think it's going to be straightforward. I think that there will continue to be challenges there. That being said, there is a tremendous amount of governance, and more so than ever before, around how do we do this well, particularly when the private sector is involved. And I think certainly for my company, governance is critically important, making sure that we are compliant with all appropriate regulations around the world. FCPA, ACAF is for us a part of how we do business every single day. So again, I think multi-sectorial, compliance, governance, critically important, and I think we can find a way forward.
Just wanted to say I absolutely love the hashtag thinking inside the box, because unless cancer patients are going to start being treated, diagnosed somewhere else, we have to start with the inside the box. Because certainly thinking about the UK, we have a National Health Service. It means that in theory everybody has universal access to healthcare free at the point of delivery. Why would we want to move it and do anything differently? But I think there is something about recognising that inside the box has got a bit stuck, and there are really big opportunities for new ways of working. So therefore, there's something about helping people inside the box understand that there's new ways of doing things in a way that makes them not feel so threatened. So having slightly different conversations about different teams of people that can help people, perhaps sometimes in more cost-effective ways, and modernising inside the box. And every now and again, opening the box and saying, is there someone that's outside that we could bring inside that could really help inside the box? So I agree with your principle, but we have to be open-minded as well.
Would you like to make a comment, Susan? Yeah. Sorry.
Mic test. I think the issue on regulatory capacity is a fundamental one and a very, very important one in today's world. There is so much technology, there's so much medicine out there, there's so much knowledge out there. And unfortunately, at least from the region where I come from, regulatory capacity is the weakest part of government. I think in the developed world, you have better regimes for regulation. But just think, I come from the world of tobacco control, and I just think about how difficult it is to do that in Cambodia, in Laos, in the Philippines, in Vietnam, in the Pacific. It's just that capability is not there. And it again goes back to that human resource issue and the issue of what are the new types of human resources that are needed in order to deal with runaway knowledge, technology, and information. So I kind of like the thinking inside the box, because governments have a fundamental responsibility to respond to the cancer epidemic. We have to start there. I think before we start blowing it out into partnerships and whatever it is, governments need to confront their responsibility and to own up to it. And then we can start thinking about the other ways of doing it. I think what's happening now is you have a wide range of possible ways to approach the problem, that government becomes less and less involved in it. So I think it's a very good issue, and it's something that we should continue to discuss.
Dr. Antwi.
I'll go in for the thinking outside the box. Being mindful of the fact that in my part of the world where the skilled manpower is not available, we don't have them to manage the cancer management centers, then the question is, where do you start from? I would want to dwell much on the advocacy, that instead, why don't we start by going the preventive way? which is less costly. So if we can equip the system, if we can equip our public health, they have been trained, but they lack the logistics, they lack the support. So if we can equip the public health directorate in any part of the world, then they can take up the battle. They can then educate even the media world. So when the news gets to the people, it is going to inform and going to help change the cycle of the people, the mental cycle of the people. And when that is getting on, then straight away we will be getting to the part where those who have taken on the bad habit will definitely run away from it. So instead of waiting until we have the problem, then it becomes difficult in solving the problem. Why don't we push money into the advocacy to make sure that the problem do not become burdensome for us to tackle?
Ophira, can I just come back to you very quickly and just ask you, your response to those? I mean, at one level, the sense of looking inside the box being enormously important, and perhaps we don't do enough of that, and enough holding to account of what it is that to mean looking and keeping inside the box. But the sense also that potentially, or as we know happens, that a binary view of just public and private and good and bad is not possible either.
Well.
I'll throw that back to you.
Agree, and thanks for giving me the chance to respond. Yeah, no, of course I was trying to be provocative, and I think I was. The idea that it's either or, no, that's outdated, and just like thinking inside the box as a solution is silly. However, I do see that a lot of, if I may say, countries that I have visited to provide technical assistance are far more eager to accept these private sectoral responses, because it assists them in being able to say, well, the cancer problem is going to be solved this way. And I can't blame them for doing that, especially when they have so many other competing priorities in health and also in other sectors. But it has to be sort of a rational approach. There needs to be some type of evidence base, some type of debate, and there needs to be regulatory oversight, not just from the company's perspective, but the government, in terms of regulating the private sector. We see this a lot with private hospitals popping up in many countries undergoing rapid economic change, which can be a good thing, but it needs to be looked at carefully before you just decide that's the answer.
Thank you, Ophira. And there was a question just in front of you, Ophira, if I might just turn to that.
So I'm Supriya, I'm a radiation oncologist from Tata Memorial, Mumbai, and my question is to Kolleen. Kolleen, Varian is a giant in radiotherapy equipment. How do you think we can make access to equipment more affordable?
I think it's a terrific question, and we've been focusing on this particular aspect for quite some time, and I do believe that we have different models of acquisition of the technology. There's the conventional capital expenditure, acquisition, services piece over time. I do think we discussed the MES model a little bit earlier. I think that makes it a very affordable approach to bring new technology on board, and it includes the training and education we've been talking about and how critical that is, so that as new technologies become available, as new clinical protocols become standard of care, people are trained accordingly to adopt them successfully and improve not only the patient outcome, hopefully, but also the quality of life. And then the third opportunity, I think, is simply looking at some creative thinking around perhaps risk-sharing models. And we've done that as well in some emerging markets to great success in terms of government programs. So lots of, I think, different venues, creativity, but making sure that we do everything in a very strict oversight way.
I'm going to come down to you, Soang, in a minute, but I just want to come to, if I could, just come to Carrie very briefly. Carrie, if you could just tell us a little bit about where the cancer, the city cancer program is, and then I'll come down to this table number 7. Can we just get a microphone across to Carrie?
Thank you. Thank you, Charles. The City Cancer Programme, or City Cancer Challenge, was set up in January 2017, so it's still less than 2 years old. So the learning cities were specifically established to learn the process, because the model that we were trying to test was, could we work with a city to bring the community together, private sector, public sector, civil society and the government, to evaluate where they were as a city, to identify where their gaps were in delivering good quality treatment and care, then to prioritize those gaps and then draw on an international community to come and solve the problem. So very much demand driven, very much you were saying earlier, Lynda, about the client being the city. And I think you've heard that from the city so far. So in order to satisfy that demand, you have to bring together a collaborative group of organizations around the world who are prepared to put their hand up and say, when that city gets to the point where it knows what its priorities are, where its gaps are, and where it can have meaningful impact, then we are ready to set time, effort, energy, and resource aside to support that city. Now, Asuncion and Cali are further advanced in the evaluation, the prioritization, and now drawing on the lights of ASCP, we've heard about earlier, with pathology, which is a common problem that has emerged across all the cities so far. Our colleagues from ASCO, and I'm sure Doug Parle is here somewhere. There's Doug over there. Again, supporting any training or education requirements on the medical oncology side. And of course, we're working collaboratively with Estro and other organizations, including the pharma industry, including Varian, Electa, Accuray, at the point where the city says we need help. Now, when it comes to purchase, that's down to the city. The city have their own way of procurement. CCAN doesn't sell kit, it doesn't do that at all. But the city has to find the gaps it has, identify the problems, and then reach out through CCAN to all the partners to actually get those problems resolved. And in time, we hopefully will see an improvement in cancer treatment and care.
Gary, thank you very much. Could you just bring the microphone to table 7, please? Thanks. Sorry, I get you to do that job, but just down here. And a cup of tea, please, as well. Thank you.
So it's Mohamed Harif from Casablanca. I believe that no progress can be made in developing countries without good human resources, well-trained human resources. My question is, there are lots of people from Africa, from developing country, who are working in Europe, in the States. Is there a way to make them go back to their country for work there?
Well, yes. I mean, the Philippines is a country also where there's been a massive emigration of. My grandmother was looked after by a Filipino nurse in England. So, could I perhaps just turn that question to you?
You know, we've danced around this problem, I think, for too long. It does involve considerable diplomacy. There are challenges on both sides. So the Philippines is the largest exporter of nurses and the second largest exporter of doctors in the world. And yet we lack nurses and doctors in our own country. And this is the same in the Pacific, where you barely have doctors and nurses, but once they're produced, they get siphoned off to the developed world. So I think until we come to, what should I say, to a sort of horizontal kind of system where there's more equity in the way doctors and nurses are paid across countries, we will always have this problem. And it's an economic issue. It's about economies. It's about freedom of people to go wherever they want to go. It's complex. It's not a cut and dried thing where we're going to have easy solutions, and it is essentially a diplomatic problem. So I guess it goes much beyond health and public health.
What we need to do is a lot of Brexit, so we stop all of this immigration. I know that was a partial answer to your question, and I think it's a very difficult question to answer. I mean, you're suggesting that perhaps there should be some pushback, but I'm not quite sure that will be easy in the context of free movement. But yes, Lynda.
I would like to apologise unreservedly for the UK shamelessly taking people from other countries. I personally am not responsible for it. But the one thing I would say is I had a lovely conversation at lunchtime today, so indulge me in sharing this anecdote. At the UICC Congress in Paris, I had a conversation with Abigail from Nigeria. Where are you, Abigail? I don't know.
I'm over here.
Fantastic. We had a conversation when Abigail approached me and said, we have a massive problem training our nursing and doctor workforce in Nigeria, and she asked whether we could help. And MacMillan is a UK charity, and we can't do work overseas. But with a little bit of not telling anybody what we were doing, we managed to do some good work where some retired MacMillan nurses were paid for. Abigail very nicely organised all of the funding to go to Nigeria to train clinicians and nurses to have the right conversations with patients. And I found out today that 3 people have now trained 160 clinical staff, and they've had really great outcomes, particularly around things like how to have conversations about breaking bad news. So I think there are some ways that we can still support that agenda, and whether or not we can do more with technology now as well. We do need to be starting to think outside the box hashtag around this workforce shortage globally, I think.
I must come to this side of the room because I realise I'm turning this way and not this way. But, so please, down here, please. Thank you.
Well, this is one of the brain drain out of Africa. I work in the US, and I just wanted to share our conversation around cities, because I live in Chicago, and there's a 12-year gap between people who live in downtown Chicago and the south side of Chicago where I practice. And so the Chicago Metropolitan Task Force came together and talking about public-private partnership. We can't do it without really strengthening institutions and without institutions being part of this. I'm very concerned if we have a private model that we're going to export out of the United States globally. It's not going to work, because what has happened and what caused the inequities that we have experienced in urban centers in these global cities is that the rich can get access to the very best cancer care. There is money there, and it's just that our resources have not been equitably distributed. So as we think about this model of financing, we really must think about equity. So when the Metropolitan Task Force started talking about equity, then we looked at where the gaps are in terms of quality. And it turned out that without thinking about quality of care, poor people, people who live in rural communities, people who live behind the city centers are not going to get the care that they need. So I would hope that as we think about the private companies developing and putting infrastructure in place, that they actually also think about the human capital that will man those hospitals, that will be there to improve the quality of care, because without good diagnosis, you cannot treat cancer.
Thank you very much. I think that's a really important point about strengthening institutions and governance prior to really going into profound levels of public-private partnership. And it seems, and I think we all share your concern, and with due respect to our American friends, we don't want to export the American model, I think, to other countries. That would be very, very complicating, although it has been exported to a number of others, including potentially, I think, the Philippines, really. Down here, please. Can I? We've got 2 questions. We've got 3 minutes left. If I could just...
I'd never think that I was going to be the defender of the private sector, but I just want to use the example that it's not necessarily more expensive. So in Australia, 50% of the public radiotherapy is delivered by the private sector. And it actually does it cheaper than the public sector, largely because of the way it manages the workforce. So because of our unionised system in Australia, the unions make it necessary to have 4 to 5 radiation therapists per machine. But in the private sector, they've managed to do that with less. So I think we shouldn't discount. We should actually take what Ofera said and look at the accountability and the regulatory frameworks, and not actually assume that private sector delivery is necessarily worse in terms of cost.
Excellent point. Just next to you, on the table next to you. Yeah.
I think as much as we can think probably the people coming from the low-income countries, that the governments might not be able to support whatever programs are put in for cancer control and management, I think we need to be very innovative on how we do things. The fact is, yes, our government might not be able to take up everything at once, and that would be an illusion to think that we're going to have everything operating under the government, but we have to start looking for partnerships as well. If you look, for example, we've got radiation oncology training, which started in Zambia. We were sending the students to South Africa. For the last decade, they've been going to South Africa. And you build a certain number, a cohort that is there, that should be trained, but they have to be helped for the standards from people from outside. And those are the ones who are going to carry on, because if you keep sending, you'll be sending 2 people every year because that's what your budget can be able to take. But if you're taking in-house, it means that you're actually having the people providing the service in the country as well. So I think we have to continue looking at ways and methods. I mean, we were part of the recipients from Pink Ribbon, Red Ribbon. They're no longer there. But we've looked at other maternal health grants that are there, Global Fund, PEPFAR, the World Bank, and trying to ride on the success of other programs to get the cancer programs going, as much as we don't have exact funding that is coming from the government. So I think every country is different, but we need to be able to look within the box to a certain extent and look outside the box as well.
Well, thank you. I'm sorry, but we have really run out of time, and I am conscious that I'd just like these panelists to make a final comment around some of the issues we've been addressing in this panel. Perhaps I can begin with you, Susan. Just your final thoughts to take away.
My big takeaway from this conversation is the one on human resources. I'm big on leadership, I think. It's leadership that steers change in our world. And what I'd like to see coming out of this big meeting, which I think is a question we want to ask ourselves, right? What happens the day after tomorrow? I would like to see more public health people going into cancer. And our conversation about legislation is about using the tools of public health, which is law, epidemiology, surveillance, financing, and applying it to a particular epidemic that's happening, and using those tools to bring down the modifiable risks, morbidities, and mortality. So we need to have more public health people out there. I'm not diminishing the importance of the people who do actual services. I'm just saying that we need to manage the entire system, and unless we get leaders out there who can do that, we are going to continue to struggle with the tide, the sea of demand. So there's got to be a balance there.
Leadership, wonderful. Dr. Antwi, just a final brief comment, if I can.
Thank you very much. Well, so first of all, I want to thank the SECAN project for coming to our aid. And as much as we in the developing country will have to take our destiny into our own hands by supporting in a budgetary way, I also want to appeal to the manufacturers of the drug that even though we are talking about information flow, access to cancer care, what comes after is the treatment, but the cost of the drugs are so expensive. Well, I know that they are doing it, they are manufacturing it for profit, but if they don't review their prices, it's also going to be very difficult for we in the African countries to buy into it. And again, I also want to take advantage of this fora by appealing for support for the training of our oncologists in our part of the world. For instance, in my city, we have 53 hospitals, but fewer of them can boast of oncologists. the special skilled professionals who can manage and help in the treatment of cancer patients. So advocacy can go, early diagnosis can take place, we will find them, but where lies the professionals to treat them? So this is my appeal.
Thank you, Dr. Antwi. Lynda.
I wanted to bring it back to the patient, and I think with the greatest respect and remembering that we do, as system leaders, know some things that work and want to make sure that they are integrated in our healthcare systems. I think I would challenge myself and others to say, when developing our plans, remember to ask the patient what's important to the patient, and remember to check that the plan you're developing bears some resemblance to the answer that they've given.
Thank you. Kolleen.
I think today for me, this afternoon especially, has brought home how incredibly motivated I am to serve the CCAN program as a member of the inaugural board. And I think clearly there are some very significant and positive steps that we can take forward. They won't be perfect, but I think we do need to take action in the cities. And I think it's going to be a combination of tools. Clearly, based on the feedback here this afternoon, a very significant part around training and education so that we can increase capacity of skilled resources to implement the tools, whatever they may be, to help cancer patients. And it's about improving quality of care and quality of life.
Well, thank you. We will be, in 20 minutes, 25 minutes, be coming back to hear the final calls to action. And this panel has been about those actions. I just want you to please join me in thanking a wonderful group of panelists. Thank you. Thank you very much. And we look forward